Sorry, he's the campaign coordinator for ISODEC, and he also happens to be a steering committee member of this campaign. And I have also Sidua, who is the national campaign coordinator of Universal Access to Healthcare campaign. I've spoken to Sidua a few times on the phone. I remember when we discussed the lack of access of doctors. I think it was in the upper west region. You spoke a bit about that, and the way the increases in the user service charges in hospitals and the effect it would have. You were quite concerned that it would negatively affect access to healthcare. But this particular report which you have released is quite scary. You're saying that if we follow the present model the NHIS is working on, universal healthcare coverage for Ghanaians will take us 68 years. That's quite alarming. Give me a bit of a background about this report.
Thanks, Bernard. You recall that way back in 2009, the campaign produced a similar report, which was titled Achieving a Shared Goal, Free Universal Access to Healthcare. And that was like a watershed, because in that report we said that the coverage as at then could be as low as 18, contrary to the coverage as at that time. And it was a lot of that other than they contested it. It took us a number of years before finally they conceded, and then accordingly revised the coverage figures down. And so we have been so interested in the National Health Insurance Scheme, because we know it's the best, one of the best policies that probably has ever happened to this country, and that we must do everything possible to make sure that it works. And in order that we can make sure that it works, it means that we must constantly look at it, keep our eyes on it, see what is working well and what is not working well, what needs to change, what needs to be reformed to make sure that things work well. And so it is on the basis of that, when the National Health Insurance Authority were marking their 10th anniversary, we decided to do a reflection. The campaign coalition decided to do a reflection on how far the scheme has come, and when it can take us to where we want to be. You know, everybody should have healthcare, should have access to healthcare, because health is such an important thing that if you don't have it, then your very basis of existence is defeated. It is a healthy population that can keep this economy going. You know, the farmers in our rural areas who feed us every day, the market women, the drivers. If they are sick, the economy, they are not. If they are well, the economy will grant to a health.
So when we talk of universal health coverage, what do we mean?
We mean that a country like Ghana, anybody that is living in this country should have access to health care as and when they need it,
irrespective of how much money they have in their pocket.
Whether you are working or not, you should have access to healthcare.
Is it possible? Is it not utopian?
It's not utopian. It is about doing the right things.
Okay.
Because that's what we call risk pooling.
Okay.
You know, because you have two thresholds. Those are the lower bottom or lower ebb of the society, and those are the higher echelons. There are some people who are high earners. There are some people who are low earners. But the two extremes both contribute to the well-being of the society.
Where are we presently with coverage?
Coverage is about 36%.
36% of the population are covered by the health insurance.
Yes.
So per the plan we have, by which time should we have had 100% coverage?
I think at the time we introduced the scheme as a nation, we said that by 2015 we should be getting to universal.
So they give themselves a 12-year window, because they started in 2003.
Yeah.
And so in your 10th year review, how close are we to achieving the full coverage?
We are rather far off, because if the coverage it's not even 36, it's about 35, we just decide to run it off. If as at 10 years, 2013, the coverage is about 35% of the total coverage, it tells you that the 70% we still have a lot to do, you know. So that is how serious it is.
So, Doc, it appears the presentation from the campaign focuses on the financial model of the health insurance scheme. So, tell me about why you looked at the financial model and what else you found about the current financing model of the health insurance scheme.
All right. Thank you very much. I think the point I would like to make from the onset is the fact that we as citizens do have a contract with our government, what we call the social contract, because we cannot, on individual basis, build our own healthcare facilities, schools, and all that. we agree to pay taxes to the state so the state can provide these facilities for our collective use. That's how come we don't have a situation where each family has its own clinic, hospital, and stuff like that. They are provided from the pool of resources that we contribute in terms of taxes, and then the state provides this for us. But we do recognize that sometimes it becomes difficult to meet the full cost of providing social services from the budget, and so some costs are imposed at some point, and this actually let some people fall through the cracks and are unable to access essential social services such as healthcare. Now, the current arrangement for financing the healthcare in Ghana is a combination of things. It's a combination of tax and premiums. So there's an element of out-of-pocket payment, but not at the time when you need a service. You pay in anticipation that one day you will need a service. We need to accept that not all of us make use of the service even when we pay.
Good.
And so when we talk about coverage, we really are talking about those who are actively using the service. There is a problem with the current financing arrangement because if you're talking about universal access, then of course you need to be able to identify the barriers to access, and I think cost is undoubtedly a barrier to access, as we found in the case of education. You made a point earlier about it not being utopian, and I think at the time when we're talking about universal access to primary education, Ben thought that it was difficult to achieve.
Yeah.
Even the Constitution itself thought that it wouldn't be difficult,
It's really possible to achieve.
Exactly. But then gradually, somehow, we've managed to make some progress along that line. I need to make the point again that I do not see us achieving 100% coverage. Why? Because not everybody would want to subject to national health insurance. I personally am not a subscriber to national health insurance because I hardly fall sick. And then, so I think that as and when I fall sick, I may be able to take care of myself. Besides, too, I find that the kinds of illnesses that actually are very costly are not covered by the national health insurance. The minor illnesses like the malaria and stuff like that are things that I can kind of take care of when I fall into those situations. And so that is my personal take on that. But I believe that for many, or for the majority of our people who actually live below the poverty line, even a token premium could constitute a barrier. I recall when a couple of years ago, there was a massive flooding in the north. And ISODEC decided to intervene, raise some funds, and wanted to supply some drugs to the people affected areas. We were told, particularly in the Mampusi area, by the certain communities that they would rather that we pay the national health insurance premium for them, because if we send these drugs, they will be sent to the clinics,
and they can't afford
to go to a clinic, and therefore they won't be able to access the drugs. And so for these people, yes, the premium is a huge barrier to their access to healthcare. And that is why we think that if we really want to achieve universal coverage, then we need to identify this cost barrier, eliminate it, find other ways of financing the access to healthcare so that everybody who is willing and in need of the service will be able to.
So one major problem is the premium.
Yes, it's a premium.
What else is wrong with the current financing model?
There are inefficiencies in terms of that's a general problem, a general malaise in the economy, leaks, mismanagement of funds and stuff like that. But again, you see, there's a component that is from VAT. VAT, in my view, is a regressive tax. Really? It makes both the rich and the poor pay the same rate. It does not take into consideration how much money I am. So you could be a millionaire, but if the VAT requires that you pay 2%, you pay 2%. And the poor man also pays 2%. Now, what you are doing is that invariably, if you look at the percentage of the poor person's income that goes to pay the VAT, he is paying more than the rich man.
But as the fact that the VAT is not charged on food and certain items that poor people are more likely to consume, balance it out in a way. Because the argument is that we charge VAT on stuff which are more expensive, or which are more goods that are more likely to be afforded by people who are higher in the echelons of affordability. Yeah,
no, you're right. That is a welcome kind of assumption that actually helps to alleviate the plight of the poor. But the VAT are even on milk, on Milo, on all the kinds of things that we need for nutritious purposes. And so it is not really entirely true to say the VAT is exempt from food. There are certain food items that attract
certain kinds of
food.
food.
And I don't think those can be described as luxurious food. I don't think there's anything like luxurious.
So if you're talking about sustainability and you're saying that because we get money from the value-added tax, which is a regressive tax, in the long term, it's not a sustainable way of funding the scheme.
Well, it is. You need to have a combination of things. But currently, as we stand, we are not able to generate enough from the VAT to help us eliminate the premium. Because the premium for me is a main barrier to access for the poor. And so how do we eliminate the premium and then replace it with other modes of financing? And I think there are other things. We need to be very innovative in this regard. I cannot see why we cannot target, for instance, companies that produce alcoholic beverages, because there are a lot of health and diseases that are related to the consumption of alcohol. But somehow we've left them off the hook. And so you look at the budget and you don't see any particular targeting of alcoholic companies in terms of raising funds from them to help meet the health cost or in terms of access of the people to healthcare. Again, you find that even extractive companies, the mining companies, the oil and companies, and all that, their activities create some environmental health hazards for people in their community. Could we, for instance, target them and make them pay a little bit more to complement whatever we're able to raise from existing arrangements, with a view to eventually eliminating the premium that poor people have to pay?
It's interesting you say that, because I thought the concept of insurance meant that, as you already said, we all pay. You don't possibly fall sick often. Somebody may be falling sick often, but because different incomes level pay, it provides a buffer for the poorer. Yeah. But you're saying that the premium has become a barrier for poor people particularly.
Yeah.
Should the solution then not be properly demarcating who's poor from who's rich and targeting the premium or grading the premium? Because if you knew that Bernard earned 1,000 a month and Philip earned 200 a month, Bernard's premium could be 10% and Philip's premium could be 10%, but it would be different. Is that part of your proposal? Or for you, because the poor can't afford, let's just take the poor off the premium and look for alternative ways?
Yeah, I mean, you see, no matter what you do, like I said, those in the affluent society may not actually sign on to the NHIS, NHI, because they can afford out-of-pocket payments. But make it possible so that when I'm ill, I do not have to pay at the time when I need the service. But then again, make it possible that I do not have to pay to get onto the NHIS, so that I'm able to willingly enroll. For instance, we have in the situation of the free universal access to education, basic education. You do not have to pay, and therefore we saw an increase in the enrollment levels because people would normally go. But then you still have people who would opt to take their children to expensive schools because they can afford it. So in that case,
in this case, poor people can take their kids or themselves. They can go to hospital once they are sick because the premium doesn't become a barrier anymore.
Exactly. Yeah.
Now, Sidua, so far I've understood the issue of inefficiency. I've understood the premium and as a barrier, but I still don't get how you came about 2076 as the year that will achieve universal coverage. 68 years from the target date. How did you arrive at 2076?
Okay, Bernard, thanks. There are a couple of issues that you raised with Steve. I'd just like to comment on it briefly. You asked about the problem with the current financing model. Straightforward, we have the revenue coming from three main streams. We have the premiums, we have the Senate contributions, and then we have the VAT. Revenues coming from the VAT constitutes 70% of the total revenue. That of the Senate contributes about 20%. Now, what is coming from the premium is less than 4% of the total revenue. So if it's like a tray wheels, you realize that of the premium is not pulling its weight. And that is why we have a problem. We are not also saying that people shouldn't contribute in any way. We're saying that the premium is a barrier to poor people's access to healthcare. But there are innovative ways we can raise money in a more sustainable way, such that the National Health Insurance Authority will not have difficulties reimbursing healthcare providers. There are so many innovative ways. And that's why we're saying that, look, instead of them spending a lot of resources in trying to collect the premium that is already contributing very little relative to the other sources, let's take it off and take the barrier, and by taking it off, we have taken the barrier off. And then we look at the other realistic and feasible ways that can bring sustainable financing to the scheme.
But as you say that, you are cautioning that the tax is the VAT is retrogressive.
Yeah, yes.
Because the other two options are the tax and the state
VAT is
contributions.
retrogressive, but the way it is now, that is the backbone. So we are not necessarily saying that they should take the VAT off. It's okay, but in theory it's retrogressive.
Good.
But if we look at it, it's okay for now. And so we are not saying that
you should take it off.
No, we are saying that the premiums should go off. Keep the VAT, and then there are other areas we need to open our.
And these other ways include what it says: tax alcoholic beverage companies and tobacco, tax the mining sector, timber, oil sector, and then you say take off the free zones waivers.
Yes, as part of creating equity in the country, the free zones thing was introduced to ensure that we don't have all the companies being started in the cities, so that it will increase the rural urban drift. It was said that if you located your industry or company
in a deprived area, you get some waivers. So why should we take that off?
So what happened over time is that you have this company hanging around Kaswa, Kaswa in the central region,
which is effectively Accra.
They just hang around and enjoy the waiver. So over time, we have not really seen anything significant in terms of the industry moving to the deprived area. And so we're saying that it has not a very objective for which this one.
So we are just losing revenue.
Exactly. So let's take it off, and then we.
But there's
bring in
been
the
also
money.
questions of delays in the payment.
Yes,
which seems to be the big elephant in the room.
Have you addressed that? As we talk now, the National Health Insurance Authority, if they have paid out, or maybe it's yesterday, they owe the CHAG, Christian Health Association of Ghana. I know there are a couple of hospitals that I know they owe them. The Minister of Finance owes the National Health Insurance Authority about 4 months arrears. 4 months. Okay, and what is even more disheartening is that I remember at the stakeholders meeting at La Palm Royal Beach, that was in December 2012, when the National Health Insurance Authority put stakeholders together to look at ways we can sustain the scheme financially. There was a consensus that there was a need to increase the VAT by 1.5%. So that is from the 2.5 to 3.5. It went through. But what is happening today is that it appears that 1.5% increase in VAT has been shifted to the infrastructure fund. Sadly enough, and that is it.
That's what is emerging.
And now the National Insurance Authority,
that would be illegal.
And we are looking for the opportunity to where we can ask Setakwe, the Minister of Finance, why that, and we are still asking how come that the Minister of Finance owes the National Health Insurance Authority 4 months arrears, because we know that we have the VAT, the NHF fund, and that money should be there. So there are questions Setakwe need to answer. Seriously, most of the issues that the National Health Insurance Authority is concerned with are not necessarily they are making. There are issues that sometimes they might not be able to say, but these are the realities. Setakwe will have to come clear. We need to know that in that CAFES, which is meant for the National Health Insurance, and the money into that is constant, unless somebody has dipped his hand to it.
Aren't you crying more than the bereaved? We've never had the NHIS boss or NHIS people come to say finance ministry is killing us, pay us our monies. They don't say much. They seem to be okay. I've never heard them come out to complain.
Bernard, that particular point is very symptomatic of the manner in which we manage funds here, and that is why some of us are worried when in the 2014 budget the government indicated that it was going to set up more funds, the road infrastructure fund and all that, because look, all the funds that we set up in this country, they've always been in arrears. The GET fund, the road fund and all that, they collect the money, they will not actually pass it on. But then they don't come crying and about it, because they are part of the establishment, and that is the reason. And it is us citizens who come into contact with some of these realities that will raise the alarm. And so yes, it is a problem. National Health Insurance, who is the boss of National Health Insurance? Is it Sylvester? It's not part of the NDC. Yes, it's part of the NDC government, and therefore, yes, they won't come crying foul. It will take some of us, the beneficiaries of a scheme, to be able to raise some of these concerns. What we know is that things are not working well, and we're not getting the service we deserve.
Did you support their attempt at capitation, because they thought it was one of the ways in which they could make claims more realistic because of the abuses? They started in Ashanti, and for them, it was one of their key efficiency drives. I didn't hear you talk about capitation much. Why not?
Bernard, we support capitation, And our reason is that with the capitation, once they've agree on the per capita rate, then we wouldn't have this situation whereby service provider will be chasing the National Health Insurance Authority for their money to be reimbursed. They are paid upfront. Secondly, the challenge of over invoicing or inflation of claims will be done away with. And so it's something we support. The only concern we had at that time is that there was a need for the service providers and the National Health Insurance Authority to sit down and have an agreed per capita rate so that it is not too much for the National Health Insurance Authority to pay, and it is not also too low that the National Health Insurance clients will not get the services they are supposed to get or will not get the best services. So our issue had to do with the right per capita rate. But for us, it's one of the best ways of dealing with the inflation of claims that the National Health Insurance Authority had to battle with. But you asked a question how we did the projections, and we look at the coverage of the scheme over the 10-year period, and then we realized that, especially 2011 and 2012, we realized that the annual rate of coverage was about 0.8%. So we decided to be generous, to move it to 1%. I said, if the scheme were to increase coverage by 1% every year, it's going to take us this long. But
all years are not equal.
Yeah,
and
that is
the reason this is a conservative figure. It is why it's conservative.
But did you include the fact that the likes of Steve Manteaw and Bernard Avle may not want to use the scheme in your 100% target? He mentioned that. So that why don't we rather look for the poor people, get a threshold of people who we believe need the scheme, and then make them the 100% of the population? Because the 24 million people, not all of them would want to ever, no matter what you do.
That's true.
So your 36% may be actually closer to a reality of a 70% if you look at actually the poor people in the society.
But I can tell you that if you go into the statistics, you realize that of those in the informal sector, the total proportion of those that are exempt comes to about 80%. About 80%. So those who actually go and pay their premium, okay, they're about 20 or so. So in reality, some people are members of the scheme by virtue of the fact that they are in the exempt category. If they were actually to pay, then this figure wouldn't come so. Okay, and so that's why I do also agree that it's not.
So should we expand the exempt group?
The exempt group.
We should make it more bigger, create a bigger chunk.
What we are saying, that's why we are saying that we should find innovative ways. There are ways we can find. Everybody will contribute in one way or the other. Let me give you a specific. In this country, we have almost everybody use a mobile phone. Okay, so if I come to you and say you don't have money, you use a mobile phone, and then we say that okay, as part of keeping our health financing right, let's say that every person is going to contribute 2 cedis from our mobile phone usage throughout the year, which will be deducted across the year. So it will be like caller tunes. Okay, that if you look at the exchange rate, it's about $1 now. So say MTN has a subscriber base of about 15 million, right? So it means we will get about $50 million from MTN users alone. And there are some people who keep 2 or 3 lines. So you are going to pay, as long as you use phone, you are going to pay that 2 cedis, which will spread. You won't even realize. And these are some of the things we are talking. So you, the phone user, will not even realize it. But 2 cedis of your credit that you bought throughout the year.
So these are some of the innovative ways. How regularly do you engage with the scheme managers themselves? I mean, you are in civil society and you do your independent research. They may not always agree. Do you get the chance to interact with the NHIA? And do they agree with your projections?
But I can tell you, yes, we interact with them very well. Those days, it wasn't so. Today it is. I must say that there's a very good cooperation or understanding between the two groups. We meet, we share our research findings with them, we raise the issues. Yes, there have been so many times they said, yes, the issues you are raising, they are true, they agree to it, and that these are the things that they are confronted with, and that together we need to support them to be able to move the scheme in the direction we want it to go. And so I must say our working relationship with the authority for now is very good.
Interesting stuff. I'm talking to Sidua Ho and Dr. Steve Manteaw, who are saying that if we follow the present model of the financial model of the NHIA, it will take us 68 years to get universal health coverage under the scheme. Now, interesting comments coming through on the issue of health insurance. Efo Dela says, anytime I've had to visit the hospital, whatever drug I'm prescribed, I'm told is not covered by NHIS, and the tests too are not covered. Why? I don't know. I've never had a problem using the card. It's a blessing to me. The usability of my card here in Koforidia Central is fantastic. I save a lot of money and don't even pay a dime. Samon Nutekbo from Koforidia, Huhunya. The Universal Access to Healthcare Campaign Coalition is calling on the NHIA, the Ministry of Health, and the government to consider a new financial model, including reforms in scrapping annual premium payments, tackling the massive inefficiencies, corruption and wastage, making tax administration changes, and then the finance ministry being more prompt in payment of monies due NHIA. Now, let me remind you that mining companies are already complaining of overtaxation. The windfall tax has come up for special mention. It will be interesting to see how these companies respond to your proposals, asking that we should take money from the mining companies, the timber and oil and gas sector, and the alcoholic beverage sector to fund for the healthcare of end users. And you're saying, let's scrap totally the annual premium payment, let's reduce inefficiency, and let the finance ministry itself be more forthright with payment. Just to let you know that the issue of delay payments is not unique to the NHIA. Scholarships don't get paid on time, education payments delay, contractors don't get paid. Why should health insurance be treated differently? It seems as if we are in a post-election overspending, fiscal squeezing era. So it's not really NHIA alone that's suffering. It's a general malaise with the way the economy is. Mr. Dr. Manteaw, you agree?
Yes, but health is about the lives of people. And therefore, it's very, very important. I mean, look, I always say that the whether or not a country is able to make fast progress in its development activities will depend on two things, and it will depend on the quality of education, because that informs the kind of labor force you have. It will also depend on the health of your workforce. If they are not strong, they cannot produce, and therefore your GDP suffers. And so you need to really prioritize education and health of your people in whatever that you do, if you are a country that is mindful of making progress in your development. And so that is why I think the health should be different. Health sector cannot really be subjected to or compared with the construction sector and all that. Education you cited, yes, I get worried when we don't actually make the necessary resources available to finance education on time, because that is very critical to the economic development of this country.
We will be talking to the NHIA, not on this program, but in subsequent program, to get their response to these proposals, and also to the finance ministry on why they don't transfer funds to the NHIA on time. But that's for a different program. So let me just say thank you to Dr. Manteaw and Sidua Ho, who are from the Universal Access to Healthcare campaign, who have very serious reforms suggested for the way we run the health insurance scheme. If we want to improve coverage, we must make these urgent changes. We're publishing the full report on our website for you to get a copy of and read for yourself. Gentlemen, thank you very much for talking to us on the show today.
Thank you. Very nice day.